Hey everybody, good evening. My name is Mike Stevens. I am a first year, a PGY2, but a first year dermatology resident in Boston. It's wonderful to spend the evening with you all and talk a little bit about what a day in the life of a dermatologist looks like. And super thrilled to be able to just talk about kind of my day to day and what clinic looks like, what wards look like, and consults. Um, and so, uh, kind of without further ado, I think just to give a kind of snapshot of what we'll talk about tonight, just a quick blurb about a little bit more about me and my path from undergrad through med school, and then kind of leading up to today. Dermatology is an interesting field as a residency because it's a 3-year residency, but it comes with a 1-year what's called a prelim internship that you do in internal medicine. I'll explain a little bit more about what that means in a little bit. And then actually, of course, the kind of meat and potatoes of what we'll talk about tonight is derm. And so all of the things that come underneath that umbrella. And truly, that's one of the things that I love about the field is how you really get a little bit of everything. There's general dermatology, which is probably what you think about when you're imagining what a dermatology office visit looks like. And then maybe some other things that don't immediately come to mind are medical dermatology or med derm or complex med derm, inpatient dermatology. It goes by a lot of different names, but this is where you have rashes and skin disease that's showing up in hospitalized patients or in patients who have more complex systemic diseases. A phrase that's often thrown around is systemic cutaneous manifestations of systemic disease. I'm a little biased. That's kind of the area of derm that I really love, and you'll kind of hear a little bit more about that in a little bit. Pediatric dermatology, and so again, a very neat thing about the field is you see adults and kids, which isn't something that's super standard across all specialties. Derm path, and so of course, we do a lot of biopsies. We have very easy access to our organ, and so because of that, it's not difficult for us if we're not sure exactly what's going on to actually get tissue. And a very neat aspect of the field is being able to look at that tissue underneath the microscope. And it truly is incredible. There's this concept of what's called clinical pathologic correlation that also I'll discuss later. But being able to see the matching between what you see with your eyes through just by looking at skin, and then what you see under the microscope when you look at a biopsy of skin. Procedural dermatology, or what you may know from medical education as Mohs surgery, and then of course cosmetic dermatology. All right, so as we go, I just want to give a little bit of a background about MST in general and kind of who we are. A group of people really throughout the whole entire medical education process. Med students, residents like me, fellows who have finished their residency but are still in training, and even attendings who have gone through the process, kind of figured out tips, tricks, techniques to meet success, and are kind of paying that forward and want to help other people along the way. We have a long track record, and we truly love what we do. And then just to take a little bit of an even further step back and kind of talk about my path and how I ended up in aspiring to be a dermatologist. I am from you can see the little red dot here. I'm from the Kentucky suburbs of Cincinnati, Ohio. And that maybe throws people a little bit. Cincinnati is not in Kentucky, but the airport actually is. I'm from about 5 minutes from downtown Cincinnati on the Kentucky side of the river. I lived there my entire life. I went to a small liberal arts school called Thomas More University. This is their shield in the suburbs of Cincinnati. And then after undergrad, I moved to Philadelphia. I went to med school at the University of Pennsylvania. Did that for 4 years, of course. And then I did my internship at Brigham and Women's Hospital in Boston. And now I'm in the combined dermatology residency program that spans a lot of different hospitals: Brigham, Massachusetts General Hospital, Beth Israel, Boston Children's Hospital, the VA here in Boston. There's some suburb clinics, Leahy clinics. So we cover a lot of different sites. But that's currently the stage of training that I'm in right now. Just to give you a little bit more of a detail, because I know some of you might be pre-med and kind of figuring out, medicine and looking at medical schools, or might be medical students who are trying to figure out where your place is and what you might be interested in terms of fields. As an undergrad, of course, I was very undifferentiated, as truthfully probably you should be as an undergrad, and just shadowed many different specialties to try to figure out what I liked and what I didn't. Um, I had done a lot of research in allergy and immunology. It was basic science research, working at a bench, and then throughout medical school, I truly remained pretty undifferentiated in the preclinical part of my education up until my clinical clerkships, and that's really honestly the best opportunity. You get kind of a sampling of everything, and that's the purpose of really having all of the different rotations. And it gives you an opportunity to figure out what you like and what you don't like. I think one of the first questions you have to ask yourself as you're working through your clerkships is, do you feel like you are um, more of a more on the thinking end of the spectrum, more on the doing end of the spectrum? And you don't have to silo yourself into one of those two things. You can also find a lot of specialties that meet in the middle. Uh, I I felt that I was probably one of those people that really liked being in the middle, where you're doing a little bit of procedures, but you're spending a lot of your day kind of talking to patients in a clinical context. And as a result of that, I gravitated towards thinking about specialties like derm. And as I explored that further and started to do dermatology rotations, I that's when I think I really fell in love with the field. I dovetailed into doing some dermatologic research and focused a lot on immunobullous diseases. The purpose of this talk is not meant to drive home content, but you're going to see a ton of pictures of people's skin. They're all from Visual DX. I'm going to say it up front just to give credit where it's due, which is a great, phenomenal resource to look at pictures. And so this is an example of bullous pemphigoid, which is one of the immunobullous diseases that we looked at. And then also a lot of quality improvement research looking at things like teledermatology platforms, which are very up and coming. And then, of course, I applied to residency and went through the process of interviewing and creating the rank list and so on and so forth. Um, and so uh, from there, once you kind of, to give you a little bit of an idea of the subsequent process after med school as you work your way through derm residency. Again, I mentioned before that you start off with this internal medicine preliminary year. And so to have patient exposure in your career, you need to have an intern year that has some focus on working with mainly hospitalized patients. And that can be in the form of a medicine prelim year or a surgical prelim year, a pediatric prelim year. There are certain specialties where that's not required. The one that stands out in my mind is pathology, because you won't necessarily be having a lot of patient interaction. You're mostly working in the laboratory context. And so for that reason, then you don't necessarily have to do a prelim year. But for everything else that isn't already geared towards that, like internal medicine, pediatrics, surgical residencies, then you do one of these. And so I did mine again at Brigham, and you really do a mix of specialties. Mine tended to focus on a lot of general medicine, uh, being on the wards, rounding, writing orders, writing notes, taking care of patients, developing plans, and then implementing those plans. Um, it's a very cardiology and oncology focused hospital, and then of course every hospital has some degree of intensive care units. And then again, all of the kind of ins and outs that go into inpatient medicine, working with interdisciplinary teams from nurses, social workers, case management, physical therapists, occupational therapists, and all of the different people that are crucial to making patient care move forward, and then admitting patients to the hospital, and then seeing to their safe discharges from the hospital. And so now diving into the my favorite part of this talk, or where I want to spend the majority of the time in focusing in on derm itself. Again, the main things we're going to talk about are those different subspecialties within the field that I referenced before, kind of gen derm, med derm, pediatrics, path, and then procedural and cosmetic dermatology. So gen derm, this again, when you think about kind of your maybe family dermatologist that you might have seen as a child or have one now, we focus a lot. The kind of meat and potatoes of our day is full body skin examinations. And so what that would look like is, patients are coming in, their appointments are pretty quick, honestly, because we don't necessarily have to have a lot of these patients are well, and they're just here for screening exams. And they're very focused because we have one organ, we have the skin that we spend our time thinking about. And so as a result of the kind of, I don't want to say brevity of the appointments, but because we're able to kind of work quickly, you get to see a large volume of patients over the course of your day. honestly, I think that's one of the things that I love about gender more than anything else is just the sheer quantity of incredible people that you get to meet. There's really not many other jobs that I can think of where you are able to kind of sit and chat with people from different walks of life who tell you stories about past careers or current careers or hobbies that they have, and really, just by virtue of the volume, you get to know a lot of different stories and a lot of different personalities. The main things that we're focused on when doing full body skin exams is of course looking at pigmented lesions to make sure that they look okay, as well as other spots that might come up, and with a specific emphasis on identifying and eliminating melanoma and what we term non-melanoma skin cancer. And so these would be things that you might know of as basal cell carcinomas or squamous cell carcinomas. And I think that one of the beautiful things about this is there can be a lot of anxiety that comes with noticing a spot on your skin and you don't really know how to think about it. And it's hard. I mean, I'll be the first to admit that it's not an easy science of looking at something and being able to adjudicate that looks okay or that might need to come off. And it takes a lot of time. It takes just a lot of repetition, being able to see good, bad, and kind of creating a decision-making tree in your head that I've seen enough good and I've seen enough bad that for the next thing I see, I feel comfortable saying whether it's good or bad. The um, uh, kind of other aspects that fold into this is again on the procedural side of things, we do a lot of biopsies of these lesions when we're not sure and we need to figure it out, or even when we do feel reasonably confident but we want to be 100% sure before we commit the patient to a procedure. And so what that would look like are things like shave biopsies or punch biopsies where we're able to take a piece of skin that is subsequently looked at under the microscope. um, and so that's the aspect of the full body skin exams. Sometimes patients will come in with rashes, and these tend not to be as acute or things that might land you in the hospital necessarily, but still things that can be very adverse on quality of life. Patients can, and I mean, I can even relate to having, an allergic reaction to a substance that causes you to itch, or an outbreak of eczema, or something where it can be intensely uncomfortable and truthfully keep you up at night. And the ability to think about that and come up with therapeutic options for patients can be great, and really make a big difference in their ability to function and sleep well, and so on. um, Hair loss is a big part of many different clinics, and again, it may not seem like the most acute kind of problem that a patient could present to a physician with, but when you think about the spectrum of things that bother patients, and how you can positively impact their life, being able to help them get their hair back, or find ways to stop loss, or cover up loss, can also be very important. And the nail disorders, all of these things kind of fall under the foray of a dermatologist. Some of the things that we do in clinic, we can scrape if we're looking for fungal infections and look at that under the microscope. In the clinic itself, we can do a mineral oil prep if you're looking for infestations like scabies. This is my best friend in the clinic is cryotherapy. And this is when you colloquially think of a dermatologist as freezing something off, this is what we're using. It's a canister that contains liquid nitrogen inside. And the idea is that you're able to, if there's something bad that needs to go, freezing it will make it go away. And then we can do a lot of injections as well. And so steroids is one of the most common things that we'll inject. It's a great option for things like alopecia areata, which is a type of hair loss, or for other things that might respond well to this. And then the last thing I want to say about Gen Derm that I really have fallen in love with, and really haven't yet, as a new kind of budding trainee, been able to experience the full gamut of, but I'm excited to experience, is the continuity of patient care that you get. You have you'll have generations of patients that you'll be taking care of, that from the pediatric end of the spectrum through all the way through 80, 90-year-old patients. And the ability to see them longitudinally for annual full body skin exams and really get to know your patients is incredible. And you have direct follow-up. If you're doing any kind of intervention, you get that feedback of, yes, this made things better. And it's very gratifying when you're able to have that conversation with the patient. Like, I was really miserable, but you recommended X, Y, and Z, and I tried that and it's working amazing. And I feel so much better. Like, that's honestly what it's all about. And one of the biggest reasons why I love this field. Some of the things that we look at or see. So again, there's going to be a ton of pictures, and I promise you that none of these should be. Sometimes things can be a lot in the derm clinic. I promise you won't see any pictures of anything like that in the course of this webinar. But so for example, this is a great perfect site that you'd be thinking about, as you're doing a skin exam. If you see that, it would give you pause and you kind of wonder that doesn't look quite right. And again, it just comes from that process of good and bad and doing that enough times to be able to say, like, this probably ends on the, this spot in the upper left falls on the bad end of the spectrum, and we probably should biopsy that. This is in fact a melanoma. This is an example of alopecia areata that I was talking about before. And so hair loss, and this would respond very well to an injection of steroids in the area. And, truthfully, that it can be bothersome when you have a lesion like this. And if, with a quick fix of a couple of shots of steroids in this area, you can really help people gain a lot of self-confidence and empowerment by making this go away. I think a question came in that recordings will be, I believe recordings will be provided, but I don't, the headquarters will follow up with you. Moving down here to the lower left-hand corner, another example of a spot that might give pause to somebody who's looking at this. And this is an example of one of the non-melanoma skin cancers, what's called a basal cell carcinoma. And then this is an example of a kind of a perfect example of the kind of rashes that we'd see in the derm clinic. And this is an example of tinea pedis, which is a fungal infection of the foot. And so colloquially might be called athlete's foot. And so again, very easy to fix. We can prescribe an antifungal that should make that go away. All right, so now my favorite is med derm. And what that looks like is it's a mix of inpatient and outpatient. And you may not immediately think of dermatology as an inpatient kind of specialty. And to be completely honest, it's not. It largely is outpatient. But there are times when patients will come to the hospital or come to the emergency department with skin conditions that they want to see a dermatologist for, or need to see a dermatologist for. And kind of that's where we step in as a consult service. And much the same way that you might think of cardiology or endocrinology as a consult service. On the outpatient side, it's very similar to the gen derm that we were talking about, but kind of with an added layer of the medications that we're prescribing and kind of the ways we're thinking about these diseases have just added layers of complexity to them. And so some of the things that we might see on the consult service might be things like drug reactions. And so you might know, or you might have heard of, or will at some point hear about things like Stevens-Johnson syndrome or toxic epidermal necrolysis. There are other kind of rare drug entities that can be life-threatening, truthfully, and affect the skin in an adverse way enough that they require admission to an intensive care unit, require a lot of careful thinking and very deliberate kind of patient care to help people get better. The other things that you might see are a lot of vascular disorders can show up in the skin. You can have a lot of ulcerative diseases that can also, you can fix with medications, but again, require a little bit more added layers of thinking than you might have for something like tinea pedis and just trying a topical antifungal. And in the clinic, so specifically the clinic that I regularly rotate through, we deal with a lot of immunobullous disease. So this is where your skin has proteins that hold the surface together. And then what can happen is your immune system can recognize those proteins and make them not work as well. And when that happens, the presentation that patients have would be blisters. And it can be, again, it can be very symptomatic and at times even life-threatening. And so a lot of good work that you can do to help people in this kind of context. And we see a lot of patients with cutaneous lymphoma. And then a lot of patients now are on immunotherapy, things like what you might have heard of as pembrolizumab or nivolumab, Keytruda or Opdivo, medications that have really revolutionized the treatment of different malignancies and cancers, but come with side effects that include skin effects. And we see a lot of that in our clinic. So just to give you some examples of these kinds of pictures, this is a good example of what's called mycosis fungoides is the technical diagnosis, but it's a lymphoma in the skin. This is an example of what's called palpable purpura. It's a form of a vasculitis, inflammation of the little tiny blood vessels in your skin that cause this bleeding into the skin itself. Down here is a condition called purpura fulminans, and this happens when you have a very severe systemic disease, sepsis, infection, something truthfully bad happening that is causing little clots to form in all of the blood vessels of the skin, and what's called disseminated intravascular coagulation, and then presenting this way. And then this is an example of a drug reaction. So this is a morbilliform drug eruption. And this is where you have you can almost kind of think about it as similar to what you might think of as like an allergic reaction to a medication. But exists along a spectrum with some of the more severe, some more severe drug reactions. All right, so shifting gears then and talking a little bit about the pediatric end of the spectrum. Again, one of the beautiful things about this specialty is really how you get the whole gamut from kids to adults and everybody in between. And you work with a wide variety of ages. I've seen newborns all the way up to like neonates, like 2, 3, 4 days old and in the newborn nursery, all the way up to 18, 19. And even there are some genetic disorders that patients will continue to follow with a pediatric dermatologist later into life. Like pediatrics in general, it's a very unique field because you have your patient, you also interact very closely with the parents and the families. And one of the neat things about this is kind of navigating that dynamic and working with kind of a team approach with the family kind of at the center. You work closely with pediatricians. Children are very, very rashy. They're very good at making rashes, and generally pediatricians are actually excellent at triaging these kinds of things and often feel very comfortable managing this on their own. But when it requires an added level of thinking or requires consultation of a specialist, I think that's, again, one of the very neat things is how Derm is so interdisciplinary and you're working with so many different people like pediatricians. And then again, there's also kind of a more complex pediatric side of the spectrum as well, where you're taking consults in the hospital as well. So just some examples of the kind of rashes or things that we'd be dealing with in a pediatric dermatology clinic. This is an example of papular eczema or atopic dermatitis. This is a great example. This isn't meant to be a didactic kind of session, but if there's one picture to drive home, when you see that kind of silvery or that white scale, that's great for psoriasis. And so that's a good one to kind of lock into your head for later in your medical training. That comes up all the time on board exams and things like that. And so this is a great example. Try a topical steroid on there, or if it's more systemic, then you can try systemic therapy, or more involved, and you can try systemic therapies. Lower left-hand corner, we have acne. And sometimes people might think about kind of the ins and outs of dermatology as acne and skin checks. And it's true. A lot of what we do is this, but acne actually can be very, very gratifying. It's so easy to, honestly, I don't want to say it like that. It's so easy to fix because it can be challenging to kind of come up with a therapeutic plan. But more often than not, you can, very simple, well-tolerated therapies can really do wonders for children who are dealing with acne. And again, kind of thinking about quality of life, empowerment, self-esteem, like this can be night and day for people, and it can really help give them a lot of confidence. And it's extremely gratifying when you have a kid follow up and you've tried a couple of therapies that they've been applying and everything's cleared up. And I think that's, again, one of the beautiful things about this field is having those kinds of interactions. On the lower right, we have, this is an example of a virus called molluscum contagiosum. And it shows up as these little spots. And one of the things we can try is, one of the interesting things about pediatric dermatology, or I don't want to say one of the challenges, but one of the nuances of it is you have to be really judicious about procedures. In derm, we are it's so easy to, shave something off or to biopsy something with a punch or to freeze something. But you don't want to put a kid through that. It's scary. You have to anesthetize with needles. It's painful. There are blades. It's just, and so this is a great example. This would be very amenable to freezing, but it's not super well tolerated by children. And so you have to be creative. You have to think about other ways to go about navigating that. And you can try topical treatments that you can just dab onto these little areas and make them go away. But again, one of the neat things about the field. Um, I'm very, I have a kind of, I really love the path end of the spectrum. And I think one of the things I love the most about it is this concept here of the clinical pathologic correlation. What you see with your eyes, to me, is so fascinating that you also see under the microscope. And it's not obviously exactly the same. The microscope's going to be blue and pink, but you can draw a one-to-one correlation of what that scale that you saw for psoriasis looks like corresponds to what's happening in the top layer of the skin under the microscope. And it may be a little bit esoteric what I'm saying now, but it truly is remarkable how you can draw a one-to-one correlation between the two. What happens in the derm path lab when they're looking at the biopsies under the microscope is evaluating malignancies. Is this melanoma? Is this a nevus? Is this something else? Is it benign? If there's a rash that is kind of nonspecific and you're not sure what it is, then this can give you a lot of information about how best to treat it. And sometimes there's just spots that you don't know what they are. Derm, it can be really challenging because you have a decision-making tree and you kind of think about, I've seen X, Y, and Z this many times. And so I kind of have an idea of what things look like, but sometimes something's just non-specific, a red bump, and you don't really know what it is. And that's where biopsying it can be helpful if it can give you more information. So some examples of histopathologic images. Again, if this looks like just a sea of blue and pink to you, that's expected. So don't worry about feeling super comfortable with these kinds of things. But these are just kind of the spectrum of some of the more common diagnoses that you'd see in dermatology. This is a condition called lichen planus at the top. This is what psoriasis would look like under the microscope if you biopsied it. And again, thinking about that silvery scale, it directly corresponds to the scale crust that you're seeing up here. And kind of the raised bumps that you're seeing directly corresponds to this epidermal hyperplasia. This down here is an entity called a neurofibroma. And then over here, you have these little inclusion bodies that are called Henderson-Patterson bodies or molluscum bodies that you see in that molluscum contagiosum that I showed you on the previous slide. And then, okay, so procedural and cosmetic dermatology. So I do an excision clinic once a week, and kind of what that entails is we have patients who are seen by a dermatologist who have a biopsy of something that comes back as malignant or has to be removed further, and so it's not surgery in the sense of like major abdominal surgery where you have a lot of stitches and kind of opening up, but you do take truthfully you do take a lot of skin because you want to make sure that if it's melanoma it's completely gone. You have to make sure that it's completely gone, and so that's kind of what goes into that. A very cool part of the field is what's called Mohs surgery. And so what this is a type of a procedure where your goal is to, especially on areas that are more often cosmetically sensitive or areas where skin is really important, and you want to take as little as possible. That's where you focus in on this. So places like the hands, the face, with an excision, you take a lot of tissue just because you want to make sure your margins are clear, and you send it to be looked at under the microscope and they tell you if it's okay. With Mohs surgery, you just take what you see and no more, and you look at it under the microscope, and you make a decision: do I need to go back and take more, or do I need to? Am I good? Did I get all of it? And the idea is that you don't have to have margins. You just take the minimum amount possible until you cleared everything that you can see under the microscope. The neat thing about it is it's very procedurally involved, and so it can require a lot of what are called flaps or grafts. So you take tissue from one area and you kind of rotate it to another area, or you take tissue from one part of the body, like the leg, and you move it back up to the face. So it's very complex. You work closely with ENT, otorhinolaryngologists. as well as plastic surgeons in trying to work on this. And the main thing that oftentimes what we deal with on the Mohs surgery end is, for example, if someone's had a lot of sun exposure and they develop, for example, that basal cell carcinoma on the nose that I showed before, would be a perfect example of the kind of thing that would go to a Mohs surgeon for removal. Uh, and then on the cosmetics end of the spectrum, neurotoxin, you might know there's a specific brand, I think, that it basically is known by as Botox. Um, and of course, Botox is for wrinkles that I clearly have a lot of. You can help people avoid wrinkles and limit the signs of photoaging that can happen with time. There are also a lot of really incredible uses for Botox in other contexts. So I've done axillary Botox for hyperhidrosis, where you have a lot of sweating that can be functionally impacting or impair your ability to live your life. So there's a lot of ways that it's kind of a remarkable medication, the botulinum toxin, that can be repurposed for many different things. Fillers are what you might think of, that kind of typical brands that you might hear about are things like Sculptra. And this is used for, again, many cosmetic purposes, but again, you can also repurpose it in a lot of medical contexts too. Things like patients who have HIV and are on medications that can cause lipoatrophy, where it kind of causes a withering away of the subcutaneous fat. And injection into those areas can kind of replenish that and give it more of what the appearance it used to have. A lot of patients with connective tissue diseases like lupus lupus not as much, but things like scleroderma or morphea, which are maybe more esoteric diagnoses you don't know yet, can have wearing away of the skin, and you can put in fillers that can help bring that back up. And then laser therapy. And so lasers can be used for many different purposes. I have to be honest, the physics of it's so complicated. And to me, it's on some level still kind of magic how it works. But the things that we typically use in the cosmetic sense is a lot of pigmented things, vascular lesions, pigmented spots like a lentigo that you want to have removed. And then a lot of it also can be repurposed for other purposes as well. I think one of the most incredible clinics that they have in my program is tattoo removal is done with lasers, and they do a tattoo removal service for patients who have previously been incarcerated and acquired tattoos that they from previous to their incarceration or during their incarceration that they now want to have removed to be able to open up more opportunities for them. And that's really incredible to be able to help those people. And a great example of how, again, all of these things can kind of be repurposed for really great goals. And even on the cosmetics end of the spectrum, you really, again, make a very positive impact on the quality of life for people. There's new data that seems to suggest that Botox can be effective for helping people with depression, just really the whole entire gamut of just being able to help people and make them feel better about themselves and better about their lives. So just to wrap up, I'm obviously a little bit biased because I chose this field, but I think it's the best. And just to highlight again some of the things that I really love about it, it's just the breadth of it. If you again are having difficulty thinking about, like, I like procedures, but I also want to see patients. I like kids, but I also want to see adults. I like thinking about things and being analytical and maybe having a science component to what I do, but I also am really clinically oriented. I really, dermatology is just like a little niche within the field of medicine, big medicine, that you can kind of really truly have it all. And it's truly special. I love the continuity that you get with patients, and I think it might only be second to the continuity that a family medicine or a primary care physician might have, just because you do regularly see people who need to every single year, and you can kind of follow along. And oftentimes, what will happen is you'll document as you go, like has 3 children in grades 2, 3, and 5, and you check in a couple years later and they talk about their kids, and you can kind of watch these families as they develop and grow. It's wonderful. I love that you get the feedback in terms of what you're doing, so you'll see patients back. You try an intervention, And then you tell your patient, like, okay, let's try this medication, and we'll see you back in 2 months, and we'll see how things are going. And if it didn't work, you find out. And on one level, that's gratifying because then you can try something else to help your patient. And on another level, it also is really, I think, advantageous as a provider because it helps you get better. If you never are told whether what you did was right or wrong or helped somebody, then you don't really know going forward. You just keep doing the same thing over and over again. But if you get that feedback, then you're able to kind of, figure out that, this has been working for so many numbers of patients and that has not. So I'm going to switch gears at this point. And then I think something you have to think about is kind of the work-life balance that comes with the field that you're going into. And I mean, dermatology is very, very reasonable in terms of expectations and how often you're working. There are acute things that require you to come to the hospital or to think about on a more urgent basis. But at the same time, dermatology is great because you can have hobbies, you can have interests, you can have a family in the field, and certainly very doable to have a great career, a very satisfying career, while having still a very well-rounded life in general. Um, and so I hope that was helpful in terms of thinking about the field. If you're undecided about where you feel like you'll land in medicine, um, and just to kind of dovetail off of that a little bit and talk about MST and how we can help you with that decision making process and how we can help you kind of reach your goals to choose the specialty that you want and ultimately be able to do that specialty. Uh, Again, we are an organization that's committed to tutoring and student success. One-on-one tutoring, I have a panel of students that I regularly meet with. And what I love about it is that you have regular kind of interactions with people where you're able to get to know them, kind of learn their strengths and areas of opportunities, and then kind of progress with them as they go through their studying and their preparation and their medical training, and ultimately help them succeed on these exams. Um, there's the process is kind of listed above in terms of how to go about doing this. And we, beyond the tutoring, we have strategic planning sessions where we just talk about tips and tricks, techniques to approach to approach uh, these exams and medical school and all of the above, uh, as well as coursework and applying into med school itself. And so, with that, I think we have some time for questions. And I think some have already come in. A great question. Tips for matching into dermatology. So that's a great question, and I'm going to be completely transparent that the derm is a on the spectrum of competitiveness for applications. And I'm not going to sugarcoat it, and I'll be honest with you. The derm is a little bit more competitive. The things that I think that you can do to set yourself up for success is identify people within your program or within your medical school that you can go to for advice. In other words, finding a mentor is crucial to the process. And what that does is honestly, it's a complicated process, and having somebody who can help you navigate it along the way, kind of at every step from choosing your um, electives, putting together your ERAS application, navigating the interview process, how to approach the rank list and matching and so on. All of that, I think, it's just so much more helpful when you have someone who knows the system and can help you along the way. Derm does put a little bit of a priority on having well-rounded applicants, and so it's important to obviously study, work hard, be very motivated, and show motivation. But you also, I think, it's important to have more to your medical education and medical experience than just that. And so, I think research is super important, and showing that you're curious and intellectually stimulated by thinking about questions that haven't been answered, and also just generally being a leader within your peers, trying to find ways to contribute to the medical experience for your class and getting involved. So it's a kind of a trite, kind of a short answer to a very complicated question, but I think that's where honestly the most important piece of information out of what I just said is making sure you find a good mentor. Um, Other questions, guys. Studying in med school, I'll be honest, med school is challenging. So how much? The question is, how much did you study in med school? Med school is challenging. It's a lot of information, and the analogy they often give is they compare it to drinking from a fire hose, and that's not completely off base. You do have to spend a lot of time um, learning and reading and preparing. Um, I also, one of the things I often advocate to my students as well is you should work, you need to work hard. Life doesn't stop for medical school though either. And so it's important to still put a priority on friends, family, maintaining a good sense of wellness and finding things that are important to you that you'll prioritize, whether that be taking time out of your schedule to um, exercise or see your friends or see your family. Like these are things that I think you ultimately are going to be less productive if you try to study at this expense of those things than you would be if you took time to take care of yourself and then also worked hard in the time that you devoted to studying. So all of that again to say just be well rounded in the process. Oh, here's a great question that's come in. Should you say you want to be a dermatologist on your AMCAS medical school application? That's a great question, honestly. And I would I would probably, truthfully, if you're going to say that in the context of your medical school application, you need to have enough experience to be able to communicate that. If I were on the other end, for example, reading said application, and someone said something like that, I would be curious to know why they feel so strongly about derm and what experience. Of course, I think it's great, and that's what I want to do. But why do you feel that way? And if you've only had a couple of hours shadowing one dermatologist in one context, it's probably not enough to convince me that really represents your calling. Um, Not only do you need to demonstrate that derm is the field for you, but you also kind of have to have a sense of all of the other fields maybe aren't or not or second to derm. And I just don't know if that's realistic out of the gate without having had any true dedicated medical school education yet. And so I would probably veer on the side of not necessarily siloing yourself just yet on your application. I think it would be better to show that you're well-rounded. And if you have an interest in the field, I think you can find ways to communicate that. But saying kind of point blank, like unequivocally, like I'm going to be a dermatologist, I think just wouldn't necessarily seem as well thought out um, in the moment. All right. I think we'll wrap up tonight. Again, thanks everyone for tuning in. I hope this was helpful. Best of luck on your process through the remainder of undergrad, or if you're starting med school with the remainder of med school. And wonderful being able to spend the evening with you all. Quick reminder.